Hello, I'm Nelly. Today I'll discuss malaria, its causes, progression, diagnosis, treatment, and control measures. What is malaria? Malaria is a serious and potentially fatal disease caused by protozoan parasites of the genus Plasmodium. It spreads to humans through the bite of an infected female Anopheles mosquito. Once inside the body, the parasites travel to the liver, multiply, and then invade the red blood cells. Malaria causes fevers, chills, and flu-like symptoms. If left untreated, it can result in severe illness or death. Signs and symptoms. Early symptoms of malaria resemble the flu. These include fever, chills, profuse sweating, headache, and general fatigue. Nausea and vomiting are also common. These symptoms often begin 10 to 15 days after infection. They may be mild initially but can escalate rapidly. As malaria progresses, symptoms can include muscle aches and joint pain. One hallmark of malaria is cyclic fever episodes, which occur every 48 to 72 hours depending on the species. In severe cases, complications such as anemia, cerebral malaria, and multi-organ failure may develop, particularly in infections caused by Plasmodium falciparum. Causative agents. Malaria is caused by 5 Plasmodium species that infect humans. The most deadly is Plasmodium falciparum. Others include P. vivax, P. ovale, P. malariae, P. novelsi, which is zootic. P. falciparum is known for its rapid replication and its ability to cause severe, life-threatening disease, especially in sub-Saharan Africa. Pathogenesis. After the mosquito bite, sporozoites enter the bloodstream and reach the liver within 30 minutes. They invade the liver cells and develop into schnizones containing thousands of merozoites. When the liver cells rupture, the merozoites are released into the bloodstream, beginning the red blood cell cycle. This liver stage is asymptomatic but essential for establishing infection. Merozoites released from the liver invade red blood cells using specific receptors. Inside the RBCs, they develop from ring-size stage to tropocytes and then schnizones. When the cells rupture, more merozoites are released, causing periodic fevers and chills. Hemozoin pigment and parasite waste triggers immune responses, leading to fever, inflammation, and anemia. Virulence factors. Plasmodium falciparum, erythrocyte membrane protein 1, which is PFE-MP1, is a key virulence factor expressed on infected RBC surfaces. It allows for RBCs to adhere to blood cell vessel walls, avoiding clearance by the spleen. This cytoadherence can block blood flow, contributing to complications like cerebral malaria. PFE-MP1 also undergoes antigenic variation, helping the parasite evade the immune system. Transmission and epidemiology. The primary mode of transmission is the bite from an infected female Anopheles mosquito. Other less common modes include blood transfusions, organ transplants, shared needles, and congenital transmission from mother to child. The disease is especially prevalent in tropical and subtropical regions where mosquitoes thrive. According to the World Health Organization 2024 report, malaria caused an estimated 263 million cases and over 597,000 deaths in 2023. Approximately 95% of both malaria cases and deaths occurred in sub-Saharan Africa. The group most at risk includes children under 5 years of age, pregnant women, and travelers entering areas where malaria is endemic. Endemic regions include the tropical and subtropical zones, specifically sub-Saharan Africa, parts of Asia, and South America. This group provide ideal environment conditions for the Anopheles mosquito to thrive and spread the Plasmodium parasite. As you can see in the map on the slide, countries shaded in red indicate areas where malaria transmission is ongoing or common. Culture and diagnosis. Microscopy is the gold standard for diagnosing malaria. A thick smear is used to detect the presence of parasites, while a thin smear helps identify the specific Plasmodium species and estimate parasite load. These tests require gizma staining and are performed by an experienced lab personnel and interpreted accurately. Rapid diagnostic tests detect malaria antigens like HRP2 and LPDH and are widely used in low-resource settings. Polymerase chain reactions (PCR) testing is more sensitive and can detect mixed infections or very low parasite levels. PCR is often reserved for research or reference labs due to its cost and equipment needs. Prevention. Insecticide-treated nets, malaria nets or bed nets, are one of the most effective methods of preventing malaria, reducing incidences by about 50%. Also, the use of indoor residual spraying with insecticides kills mosquitoes that rest on treated surfaces and helps interrupt transmission in high-risk areas. Chemoprophylaxis is tailored to region-specific resistant patterns, travel duration, and patient factors like age or medical history. Common options include atovaquone, praguanil, doxycycline, and mefloquine. It's important to complete the full regimen even after returning, since parasites can remain dormant in the liver. In addition, RTS-SASO1 vaccine, also known as Mosquirix, is the first WHO-approved malaria vaccine. It targets Plasmodium falciparum and is given in 4 doses starting at 5 months of age. It is used in high-risk areas to reduce cases and severe disease, especially in young children. Treatment. Uncomplicated malaria is treated with antimenism-based combination therapies or ACTs. A common option is artemether-lumefantrine, which is taken twice daily for 3 days. Severe malaria requires IV or intravenous antesunate. Pregnant women in their first trimester are often treated with quinine plus clindamycin to ensure safety and efficacy. In conclusion, malaria continues to be a major global challenge, particularly in sub-Saharan Africa, while prevention and treatment strategies have made progress. Ongoing efforts are needed. Research, funding, and vaccine development are critical to eliminating the disease and saving lives. Here are the references that I used for this presentation. Thank you for listening.